Hello, my name is Tom Bartholomew, and I am on the faculty of Rutgers University Department of Psychiatric Rehabilitation and Counseling Professions. And I'm part of an academic affiliation with the State Psychiatric Hospitals of New Jersey. This training is part of a series on best practices in inpatient settings. And today we're going to talk about the Safewards model out of England and the Bröset violence checklist out of Norway. The Safewards model is a comprehensive model of conflict and containment. And specifically, it tries to answer the questions, what causes conflict and what causes containment? And containment, in this case, is seclusion, restraints, and involuntary medication. Conflict is violence, and it could also include patients that hurt themselves. So in this model, the Safewards model, they use some unique terms, and specifically these six. The first term, originating domains, we're going to see later in a picture of this model how they organize these originating domains. But it's just the idea of where does violence come from within these settings. And then there are things we can do about it, things staff can do, staff modifiers, things patients can do, patient modifiers. They use the term flashpoints for the situations that lead to conflict. And you may recall in previous training on 3 steps to safety that things like activity demands, denials of request, and limit setting are consistent with this idea of flashpoints, where if you're making an activity demand, demanding that somebody take their meds or go to a group or do whatever, that this could be provocative of violence. And then there are the 2 C's, conflict and containment. And in their terminology, conflict is any type of violence, whether it's directed at another person or oneself or property. And then lastly, containment is their term for what we call seclusion, restraints, and involuntary medication. So this model is going to be organized in what's called a hexagon, a 6-sided model. And so what we did is we color-coded the various components of the model so that we could try to simplify it. It can be kind of complex. So here's the color coding we're going to use. Before we get there, I want to break down the 6 domains, which is the blue part here, the originating domains. So they identify in Safewards that the staff or team domain is a potential source of violence, and this can involve the staff or team imposing rules, giving bad information, bad news, like you're not going home today or whatever. But this is violence that originates from these types of interactions, from the staff and team interacting with the patient. The next domain is physical environment. So as you know, if it's hot or noisy or crowded or disorganized, or you have to wait in long lines, these are all potential sources of frustration and violence. Thirdly, the outside the hospital domain. So this is the idea that a person may get a call from their wife saying she wants a divorce, and the person is understandably very upset and maybe potentially violent. But it has nothing to do necessarily with the physical environment or with the staff and team. It's really coming from outside the hospital. Next is the patient community. So you know that in some of the environments at our hospital here, you have multiple patients in a room. You maybe have 1 television for a large number of patients. And these are potential sources of conflict. And I suppose they overlap somewhat with the physical environment. Patient community really is about patients have to live with one another in this institutional setting. It can be very stressful. Next, patient characteristics. There's very good evidence that patients that come to the hospital with a long history of violence are more prone to violence while in the hospital. They may have learned violent behaviors, solve problems in their lives, or protect them if they're coming from urban settings, or if their family maybe was very violent. Another patient characteristic is being very ill and having a type of mental illness where person has symptoms that they believe people are out to hurt them, and they're experiencing paranoia. Also, personality disorders can predispose some patients to violence. And then lastly, regulatory framework. This is a situation where a person maybe is kept in the hospital because of the court, that the person may have charges against them, or maybe there are immigration issues or whatever it is. It can be very stressful for the person, but it has little to do with the other domains. That it is somewhat discrete. All right, so I mentioned that these terms, these 6 terms, help to understand the model. And we color-coded the terms to try to make it easier to see. So here are those colors and those terms laid out in a hexagon, in which each piece of the pie here represents a domain. So the source of violence is either in the patient community domain, the patient characteristic domain, the staff team domain, et cetera. And you can kind of see how it's laid out there. Here is the larger model, larger in the sense of little small print. And I'm guessing if you're 15 or 20 feet back from where this slide is being projected, you can't see this at all. But what this does is they filled in what the research suggests is consistent with a patient modifier. So for example, if a patient can manage their anxiety, that can really help reduce the anxiety associated with the patient community. It makes a lot of sense. So I encourage you, if you have the opportunity, look at this model in some detail. It is a little hard on the eyes. So one of the important reasons to talk about the Safewards model prior to the Bröset violence checklist is that the Safewards model can contain a lot of other interventions. In other words, it often seems like there's just so many different things going on in the hospital, and some start and stop, and it's hard to see it in as a single effort that we're all pulling in the same direction. What we can do here is look at the Safewards model and start to plug in where these other hospital initiatives might fall within this model. And so there's an initiative starting, and maybe on your unit now, called the Gold Card series, in which 10 gold cards have been developed, which are skills to manage, so a patient can manage their emotional situation, or help manage the situation. So these are things like being mindful, deep breathing, practicing some skills, identifying your thoughts, whether your thoughts are negative, that kind of thing, and a bunch of others. But it's an effort to capitalize on what we understand it would be helpful in terms of the Safewards model. So that's the Gold Card series. There are other initiatives which we're going to lay out here. So here's a trauma-informed care. And in a nutshell, trauma-informed care is the idea that patients and staff as well experience life events that can have a profound effect on them, sometimes leading to PTSD, but other times leading to behaviors that manifest later in life, such as being very sensitive to authority figures, for example. So imagine you grew up in a situation where authority figures abused you and disrespected you and invalidated you. And so now you're very sensitive to when authority figures make demands on you. And so it's an example of how being aware of what people have gone through can make a large difference in how we interact with patients and be sensitive to why they might react the way they do. 3 steps to safety. You may have participated in earlier trainings on 3 steps to safety. This involves validating, explaining why, and problem solving during and prior to activity demands, denials of request, and limit setting. And what's become clear throughout this project, the three-step project, is that the degree we validate, we're putting money in the bank in a manner of speaking with patients, and that the more staff do that, the less likely there's violence. The more validation, the less violence. But you can see how these projects, I'm going to speed up a little bit, dialectic behavioral therapy deals with, is very effective for specific patients with personality disorders and helps them learn skills to manage their emotional dysregulation. Personal safety plans are also, can be very helpful, and they identify things that are effective with each person, so they're individualized. We have that program running. We have SISU, which is a ancillary response team, and there are numerous versions of this program throughout the state. But these are a group of people who are trainers and go out and help staff react differently in an effort to de-escalate potentially violent or containment-related issues. We have here therapeutic options. So most staff are trained in therapeutic options, and these are things staff can do to prevent violence. Dynamic risk assessment we're going to be talking about today, but is a way of looking to predict which patients are going to be violent in the next 24 hours and hopefully intervene effectively. The C program, I believe, is unique to Trenton Psychiatric Hospital, but is a group of staff that respond to support other staff who may have gone through difficult experiences at work, including patient assault or if a patient passes away, things like that. R&R admissions. This is a program based on the evidence that low stimulation can be very effective, particularly on admission units. And so this is a program that for patients who are having difficulty, they can go to a very low stimulation environment, and it's shown to be effective, at least at this hospital. And you may have heard the 6 core strategies. Most of these programs can have more arrows, but suffice it to say that they do fit within this model. The 6 core strategies are another set of approaches to the reduction of conflict and containment, including debriefing, personal safety plans, the involvement of peers or patients in other hospital roles than just patient. Okay, so you can see from this, the idea behind here is not to put in every arrow that we could or anything like that, just to make the point that the Safewards model is the broad conceptual model for conflict and containment reduction in the state of New Jersey's psychiatric hospitals. And it's very helpful in that regard. In studying the Safewards interventions, 10 interventions have been used in a number of large studies, and we're not going to cover these in any detail, but they attempt to deal with the different domains with an understanding that no one type of intervention is going to eliminate violence, but that taken as a whole, we may accomplish a larger reduction of violence because we're looking at where it's coming from in different domains. So this is a little hard to interpret, but the blue line represents the experimental condition, and this is over a large number of hospitals in England that participated in the Safewards trial. And essentially conflict was reduced almost 15% in the experimental condition, experimental hospitals who were using Safewards. It also went down in the control unit, but not as much. And also containment was reduced even to a larger degree, and that's nearly 24% reduction. So if we use these strategies, we think this way, we're likely to make progress in reducing violence and containment. All right. At this point, Hello, we're back. Some of you may have just participated in the Safewards part of the training. Others maybe just are starting with the Bröset violence checklist. But in any event, my name's Bartholomew, and I'm with Rutgers University's Department of Psychiatric Rehabilitation and Counseling Professions, and part of an academic affiliation with the State Psychiatric Hospitals of New Jersey. And this part of the training is on the Bröset violence checklist. This checklist was developed in Norway, and if you're like me, I didn't know exactly where Norway was, but there it is. If you can see my cursor, this is Russia, and so Norway's way up there. It's probably a pretty cold place. And what happened in Bröset Hospital was the researchers there identified certain behaviors that preceded violence. And 6 behaviors in particular were identified, and they were confusion, irritability, boisterousness, it's an odd term, meaning loud voice, yelling, slamming doors, just generally being loud, maybe and abrasive, verbal threats, physical threats, and attacks on objects. So what they did was they realized that these behaviors were associated with violence in the next 24 hours, the presence of these behaviors. And they develop a checklist called the Bröset Violence Checklist. And the way it works is you score each of these behaviors, whether the patient is confused, irritable, boisterous, with either a 0 or a 1. And 0 meaning it's not present, the person is not confused, not irritable, not boisterous, or it is present, 1, yes, they're confused, yes, they're irritable, yes, boisterous. And so the scale, it can be scored from 0 to 6. So if you have zeros on all of those 6 behaviors, you get a 0. And if you have 1 through 6, it's the presence of those other behaviors. So, and here's what the science turned out, which was very interesting, that a score of 0 is associated with a very small risk of violence in the next 24 hours. A score of 1 to 2 is increasing risk, they call it moderate, and that this is an instance where preventative measures should be taken, including the use of the personal patient safety plan. And then scores of 3 or more, the risk of violence is quite high, and that we should definitely use the patient safety plan. But in addition, we should implement a plan to reduce violence, which may involve talking to the psychiatrist, the team, and your colleagues. So in 2 large studies of the Bröset violence checklist, the risk of violence was reduced after intervening based on these elevated scores by quite a large bit. Across 2 large studies, the reduction was about 50% in the risk of violence. So there's reason to believe that if we intervene based on these scores, we can reduce violence, or the risk of violence. So as I mentioned, the scoring of the 6 behaviors, you score a 1 if the behavior is present, and you score a 0 if the behavior is not present, resulting in a score of 0 to 6. So this is called a dynamic risk assessment, and it's dynamic because it changes over time, unlike some static risk assessments where the person's age is a predictor or their gender is a predictor. This changes maybe hourly. The BBC can change hourly. And so it's called a risk assessment device, but it may have more value as a risk communication tool. And what I mean by that is it's fairly common for direct care staff to see differences in the client, and they may even communicate it, but there's no agreed upon mechanism for how exactly you communicate it. What does the communication mean? We say things like, "Wow, they're not right. They're gonna blow," you know, whatever it is. Well, here it's literally a score, and that may be one of the benefits of a measure like this. It also should be noted that this is a risk assessment process, and there's no sense in assessing risk if you're not going to intervene. And so some of the things we'll be talking about today are what would an intervention look like? So here is a rather complicated process map. And yes, I'm going to go through it step by step with you. So basically, this box is where we're going to start. This just indicates that staff come to work, right? And they get informed about what's been going on. They then, within 90 minutes, they complete, usually the RN completes a Bröset violence checklist on everybody. When a person's score is 0, there's no change in, there's nothing required that be done other than what you would normally do, which is, you know, nurses are by nature very caring and supportive and empathetic. If the score is elevated, so if we see the presence of one or more of those behaviors, we're going to go down this pathway, and we're going to do these 3 steps. And the first step is essentially asking why the score is elevated. A colleague of mine equated the Bröset violence checklist with a vital sign, something like a fever. And so if you have a loved one at home and they have a fever, the first question is, why do they have a fever, right? Do they have the flu? Do they have an infection? And this is an important, information to collect. So in our case, we see an elevation. We want to talk to the patient. We want to seek the data. We want to know why the score is elevated. Might read the chart or ask somebody that knows the person maybe well. Next, now that we have a hypothesis, we have a guess about why the score might be elevated. What can we do about it? What are our options? What has worked in the past? And here's where this idea of the patient safety plan, can be really helpful. And highly encourage you to consult that. There may be other occasions where the person is telling you pretty directly what the issue is, and the patient safety plan is not appropriate. So they may be upset that they can't get in the laundry room, or they got a terrible call from home, bad news, or something like that. And so the intervention may be unique to what is driving the score, but it could be that the patient safety plan is exactly what's needed, and it's, there's nothing you can do about the phone call. You just need to figure out a way to calm yourself. And that brings us to the third step, which is the intervention. So here is, we're going to try something. It could be something from the PSP. It could be just talking to the person can be really helpful, encouraging them to pace or to use the serenity room, or get involved in an activity. For scores greater than 3, there really needs to be even more attention to preventing violence, because the risk is really high. And this is an occasion where we want to use the patient safety plan, but we also want to potentially contact the psychiatrist and the rest of the team to get some support in coming up with an appropriate intervention to prevent violence. And there's as always, you can create or consult the IPP interventions for suggestions. All right, from here, sticking with the metaphor, I think it's a metaphor, of the fever as it compares to the Bröset score. After your loved one, you find out they have a fever, you've taken their temperature, you want to, maybe you try an aspirin, you try some medication, and you want to come back and recheck it, right? You want to make sure that the fever's gone down, the person's okay. And the same thing with the Bröset. So we reevaluate, did the intervention work, whatever we tried? If it didn't work, if the score is still elevated, and that's this pathway right here, then we go back and we redo the steps and see, did we miss something, or did we just need to try something different? If the intervention did work and the person's feeling a lot better and they are scoring a 0, then you can document that and go about your business. You certainly have plenty to do. So we call this a process map, and it's just a way of thinking about the flow and how does this, the Bröset violence checklist intersect with the rest of your work. So here is the form that Trenton Psychiatric Hospital is going to be using. And here you see up here behind my noggin an addressograph. And so each patient will have this form 1 per week, right? Sunday, Monday, Tuesday, Wednesday, Thursday. And on the form, you see up here a definition of the 6 items. And here is a description of the risk based on the score. Excuse me. And so the way it works is the night shift here will be rating whether the person is confused. If not, 0. Whether they're irritable. If not, 0. If they are confused, 1. If they are irritable, 1. And so you sum this down here, right? You add these all together, and you would get a score from 0 to 6. If the score is elevated, then it's time to figure out why, come up with what's worked in the past, what do you know about the person, what are the options, look at the personal safety plan, and try an intervention to support the person to getting to a better place. And so it's done for 3 shifts. And so when these are completed, you'll see 1s and 0s throughout this entire week, and you'll see the sum. Now, if there is an elevated score, this is where you would put the update. So when you do a second Bröset checklist, you would put that number here, and then you see the person is also putting the time and their initials. And in this way, we're not only communicating, but we're talking about whether the interventions on the units worked. Alrighty. So on the back of this sheet, which hopefully you have in front of you because we're going to do some practice, you'll see this protocol. And I encourage you to look at this in some detail because it can be very helpful. So just very briefly, I'm not going to review it in agonizing detail. Might be agonizing for you, who knows. But nurses with the input from direct care staff. So it's really helpful that we think of this as a communication process. And so the direct care staff have terrific information about patients. They spend more time with patients than anybody and are a wealth of information, in my opinion. So the nursing with them score each patient. All positive scores are reported in the cross-shift nursing report, and any positive score above 1 in any categories requires a supportive intervention. And so here you have some flexibility. The recommendation is you seriously consider the personal safety plan, patient safety plan, because this is already an individualized list of interventions for that person that was developed with that person. And also options are to look at the recovery management plan as sources for strategies. If the score is 3 or more, no technical problem. If the score is 3 or more, then you want to take even more steps. So if the score is 3 or more, you want to take even more steps and involve the psychiatrist and the treatment team to see about immediate behavioral or pharmacologic intervention. And of course, pharmacologic are medications. As to documentation, this will be done in the individual's progress note and on the nursing 24-hour report, including the assessed score of greater than 3 and observed risk factors, all interventions, the individual's response, and a reassessment of the risk factors. In other words, the update, which we discussed earlier. So what's really important is during the team briefing is that we're collecting information about what are the risk factors for this person, what are they scoring, what are interventions, and what are the results of those interventions, which can be really helpful going forward. All right, then the last piece of that is a documentation of the risk and preferred management strategies in the RMP. Okay, so move on to number 4. In an effort to reduce the burden of this Bröset violence checklist, because it is a new thing and gosh knows people are time pressured and have plenty to do. If an individual scores 0 for 7 full days after admission or first coming to the unit, or after some previous change in the risk factors, you can stop scoring them. And then you would start again if something changes again, if they seem to be exhibiting some of these risk factors or other concerning behaviors. So we're going to use one checklist per week. As I mentioned, you saw it went, I believe, from Sunday to Saturday. And then you put a new checklist in the binder on Sunday on the 11 to 7 shift. All right, and then you file the finished checklists on the unit in a binder alphabetically by patient name, retained for 5 weeks. After 5 weeks, remove, discard the patient's oldest copy. So this is not a formal medical record, but is literally a checklist. All right. So at this point, you've lived through the wonky part of the training, and now for something completely different. I'm going to show you a bunch of scenarios, and we encourage you to score the scenarios using your checklist that you have in front of you with the protocol on the back. And we're going to tell you what the experts thought the scores were. In the end, it is not critically important that we get exactly the same score. What's important is that we identify elevations in the score. So any score above a 1 is going to receive an intervention anyway. But nonetheless, we're going to keep refining our ability to score a situation. And it's good food for thought and fodder, that kind of thing. All right, so good luck scoring, and I'll see you next time.